Good afternoon. Welcome, everyone. We'll give it a few more seconds to make sure everybody's in okay. Okay. We'll get started. Thank you for attending today's press conference. The topic for today will just be going over the work of the COVID-19 residential care strike team. The participants we have today are Dr. Rachel Herlihy, State Epidemiologist, Scott Bookman, COVID-19 Incident Commander, Bonnie Silva, Strike Team Co-Chair, and Randy Kuykendall, Strike Team Co-Chair as well. I'm Jordan. I'll be moderating today. As a note, we do have both ASL interpretation as well as the Spanish language channel, which you can find in the Zoom menu bar. And we'll do a presentation and then a Q&A at the end. If we don't get to your questions, or if you have something a little bit out of the scope today, you can send us an email at media_info@state.co.us. And we'll use the raise hand function to get you in line for your questions. And with that, we'll kick it off with Scott Bookman.
Thank you, Jordan, and thank you all for joining us here today. As we approach the one-year anniversary of our first COVID case in Colorado, it gives us an opportunity to reflect on the work of the last year, to provide you all with an update on where we stand today, and really to talk about the future. As we see the light at the end of the tunnel with increased vaccine supply across the state. And so I do want to start by simply taking a moment to acknowledge the absolute tragedy that COVID has brought to our world, to our country, and to our state. We have seen thousands of lives lost. We have seen damage to our economy. We have seen people lose their jobs. We have seen restrictions that have resulted in people being unable to see their loved ones. And we have done all that we can over the course of the last year to save as many lives as possible, and to ensure that we do all that we can to ensure normalcy in these incredibly abnormal times. And so I'm really pleased today to be joining this team to give you an overview of the work that we have done to protect those who are most vulnerable from COVID, and those who have in many ways suffered the most over the course of the last year. You know, as we saw cases begin across the country, Governor Polis reached out to his former colleague from the House, Governor Inslee from the state of Washington, early on to ask him if he had any advice, since Washington was about 2 weeks ahead of us. What advice could he give? And what he told us and told the governor is focus on your long-term care facilities. Focus on your nursing homes. This is where this illness is getting in. And so from the very beginning, our state response has really been focused in many ways on ensuring the safety of those who are most vulnerable and living in these long-term care facilities. Our very first public health order was designed to protect this population. And while we come here today and acknowledge this tragedy, we also have an opportunity to really talk through the successes of this team and the work that has been done to save countless lives over the course of the last year. And so now I'm going to turn it over to Dr. Rachel Herlihy to talk a bit more about this.
Good afternoon, everyone. Next slide, please. So since the beginning of the pandemic, we've used epidemiologic data and modeling data to support decision-making, including around our primary goal to protect Colorado's healthcare capacity and ensure that all Coloradans with COVID-19 or with other healthcare concerns, so things like trauma due to motor vehicle accidents or a heart attack perhaps, were able to have access to the healthcare that they needed, especially that highest level ICU type care. So the figure that's shown on this slide is from the Washington State-based modeling group IHME, or the Institute for Healthcare Metrics and Evaluation. And what this figure does is it compares the stress on healthcare systems in different states throughout the pandemic. This figure is specifically looking at ICU beds and shows that Colorado, which is shown in the red box and with the arrow, successfully avoided extreme stress. And they're measuring these levels based on a percentage of beds in a state that are occupied. And if you look, we only have that small sliver of orange in the row for Colorado, meaning that we only briefly experienced high stress in the state. So again, showing that we really successfully managed our healthcare capacity in the state and avoided exceeding our healthcare capacity in the state, especially when measured against other states other states in the country. Next slide, please. In comparing Colorado to other states with regard to cumulative case counts, you can see in this figure that efforts of this team and all Coloradans really through things like mask wearing, social distancing, hand washing, and all of the other actions that Coloradans have taken have been able to keep rates here in Colorado below the national rate for really most of the pandemic. Next slide. And very similarly, when we compare death rates in Colorado to US state death rates, you can see that Colorado has consistently maintained rates that are below the national average. Again, so Colorado's actions have really saved more lives. And with that, I'll hand it back to Director Bookman.
Thank you, Dr. Hurley. And so, the impact on long-term care facility residents of COVID-19 has obviously been incredibly significant. And I think that this slide really lays out with a lot of specificity exactly what we have been up against in our work to protect this population. More than 15% of all outbreaks of COVID-19 have occurred in long-term care facilities within the state of Colorado. 38% of all deaths from COVID have occurred in these facilities. That's more than 2,000 Coloradans residing in long-term care facilities have died from COVID. It is why we have taken such extraordinary measures and put so much effort into protecting this community. 50% of all the COVID-19 tests across the entire state over the totality of the pandemic have occurred in our long-term care facilities. That is almost 1.3 million tests in a year designed to protect this population. And there is a light at the end of the tunnel here. And as we have seen vaccines arrive in our state starting on December 14th, our top priority from the beginning has been to save as many lives as possible, distribute vaccine with equity, and minimize this crisis as quickly as possible. And so we have vaccinated 135,000 staff and residents within our long-term care facilities. 28% are now fully vaccinated. And this really sets us on a new trajectory in this crisis within these facilities. Vaccine is making a difference. Vaccine is making a difference in these facilities, and it's going to make a difference in our broader society in the days, weeks, and months to come. Next slide, please. We have had a year of non-stop work to mitigate the spread of COVID throughout our state, but in particular within our long-term care facilities. As I mentioned, our first case was on March 5th. By March 13th, we issued our first public health order to restrict visitation at these long-term care facilities. By March 20th, we were working with our federal partners to suspend our routine investigations in these facilities so that we could focus all of our efforts on infection control investigations to ensure safety. We've done all that we can to assist with PPE and staffing. We created this residential care strike team for the sole purpose of bringing all of the efforts and all of the strength of state government to protect this population the best that we can. We have done all that we can to increase testing. We have issued a public health order to include surveillance testing. We worked with our public partners and our private partners to ensure that we had all of the testing available both within these facilities and across the state. And so, that really brings us to date, and now we're working tirelessly on our vaccine campaign to ensure that we are getting shots into arms of those who need it the most as quickly as possible. Now I will turn it over to my colleague, Bonnie Silva.
Thanks, Scott. So you talked a bit about the, putting all of state governments, force towards, addressing the impact of COVID in these long-term care settings. And, thankfully, Governor Polis had the foresight to understand that it would require a truly uniformed response. And early in the pandemic, created the residential care strike team and charged this team with coming up with the key focus areas where we believed we would have the most impact and the most chance of saving lives. So we had a uniformed response at the state government level. I want to highlight that response was really closely informed with our key stakeholders on the ground. We worked really closely with the providers who were at the forefront of this pandemic, and worked hard to provide changing guidance as we learned more and as we knew more. And looking back, we issued over 170 written communications. We have held weekly meetings and webinars, sharing information from the state level and certainly hearing feedback from the ground. And we have a webpage entirely dedicated to the work of the strike team, where people can go and find out information around the work that we are doing. So we identified 6 key priority areas, and I'm really thankful to say that we've now added a 7th, and vaccines really is the game changer and what we are now adding to our efforts overall. Really quickly, we're going to do a deep dive on these 6 strategies, but we focused early on enforcement and education. We had to ensure that there was proper implementation and understanding of those infection prevention measures. We then also focused on cohorting and facility isolation so that we could provide expertise to those providers on how to prevent the spread once it got into that residential care setting. We also did a lot of work on situational awareness. We had to create insight at a state level about what individual facilities' needs were so that we could partner with local public health agencies to be responsive to things like critical personal protective equipment shortages. We also focused on staffing to ensure that, as staffing shortages would occur, that the residents that were in those settings would continue to get their care needs met. We also have an area around health, wellness, and equity. I think we quickly understood that this pandemic would not be something that we would be able to get quickly out of. And so we put a lot of focus on what are the social and emotional needs of the residents and the staff that support them. And then, of course, testing for disease presence, to identify COVID and asymptomatic carriers, but also to inform outbreak strategies once the carrier was identified. So I'm going to now pass it over to my partner, Randy Kirkendall, who will walk you through those first 3 strategies.
Thank you very much, Bonnie. I appreciate it. The first strategy that was obviously one of the most readily available to us was to bring our enforcement and education component that exists in Colorado all the time, to bring that to bear on this particular problem. As of March 20th, as Director Bookman mentioned a moment ago, all of the routine survey and inspection, facility inspection activity was suspended in favor of implementing and putting all of our resources into infection control surveys. And I think it bears noting that within the first 100 or so days of the pandemic, starting in early April, all 1,153 healthcare facilities were touched by survey teams, meaning our opportunity to both conduct a survey as well as provide education and assistance, as well as seeing a line of sight as to what was going on out in the field. We were all learning a lot in those days. I think it's important to notice that bringing those actions to bear early on gave us then the opportunity to begin to gauge the production and supply chain issues with PPE that everyone was encountering, including our state and federal surveyors that were out in the field at that time, and working with them on solutions to address this pandemic as it began to spread. And I think we've all seen that continue to be a bit of a struggle as the year wore on. As we learn more about how the virus spread, we instituted new requirements in our PHOs, the very first PHO issued, was to include mask wearing screenings going into facilities, because we didn't fully understand, I think at that point yet, how the disease spread. So we started there, and limitations on visitation were put in place under the public health orders in an effort to stem the flow and take the advice that Governor Polis had gotten from the state of Washington. The facilities were responsible then for developing infection control plans. I think it's important to note that of the 1,000 plus facilities that are out there, about 230 of those are nursing homes, with the remainder being assisted living facilities of a variety of types and capabilities, as well as group homes and IDD homes. So many of those facilities had not really faced an infection control issue of this magnitude up to this point. So having our PHO put in place to aggressively ask those facilities to write those plans and bring those to us also gave us at the department and the strike team the opportunity to provide support and help them learn how to operate under these conditions. I think it's also important to bring to notice here is that all of the operators in these over 1,000 facilities suddenly faced many additional costs that they had not been facing before in the care of this vulnerable population. And so the JBC, Joint Budget Committee, authorized $20 million in enhanced payments to be distributed by healthcare policy and financing to help offset some of those costs and provide some funding to support the addition of some the new techniques, new equipment that was going to be needed to keep people safe out there. It's also important to note that another 17 million has been authorized this winter to support those facilities. And then finally, having line of sight on the needs of these facilities, knowing who has enough PPE, who needs more staffing, how do we communicate with them? I think it's important to note that here in Colorado, our agency has always had a solid connection to communicating out to the facilities. However, we discovered very early on that we needed to improve the ability for those facilities to more timely communicate back to us what their needs may be in those particular environments. And so work began almost immediately on developing EM resource and some additional capabilities that address our long-term care facilities. And then finally, I think it's really important to note when I mentioned that we touched over 1,100 facilities in the first 100 days. I think it's important to note that those efforts continue absolutely unabated today, just as heavily, just as frequently as when we started out. We have conducted well over 2,000 infection control surveys. That doesn't account for other surveys of enforcement capabilities that we've had to bring to bear because incidents still happen in facilities. So our enforcement efforts continue to be every bit as strong and as aggressive and assertive as we have had them in the past, not only to ensure enforcement, but also to provide support to these facilities. Bonnie, I'll hand it back to you.
Thanks, Randy. So next, I am going to talk about our next two strategies, which were around staffing, health, and well-being. So very early in the pandemic, staffing shortages, we realized would likely be a major threat to these facilities. We knew that the long-term care workforce was incredibly fragile prior to the pandemic and had turnover rates of upwards of 82%. And COVID-19 simply exacerbated the problem that was already present. As we got more data, we did a regression analysis. I think that you have to remember that, for other illnesses, we have longitudinal data, we have, things that we can look at to say, if we do X, then Y will be the outcome. We were really looking at which of these strategies had the most impact, and that initial regression analysis showed that, a potential leading indicator for outbreaks in these settings was critical staffing shortages. And so you'll see on this slide, we threw a lot of effort into preventing that and mitigating it very quickly when critical staffing shortages were identified. So some key actions we took, I will highlight. In early May, we actually launched a state-run Connect to Care job site. This is a website that was built for us for free in partnership with Centene. They wanted to do their part during the pandemic, and it is, a website that's entirely dedicated towards the long-term care workforce, the staff that want to work in that industry, and the providers who are desperately looking to fill those shifts. So we launched that early on. We also worked hard to make sure that those frontline workers that we quickly came to understand were on the front lines of this pandemic had the training that they needed to implement those infection prevention strategies in this setting. So we made available free COVID-ready caregiver training programs for them. I remind you that these are primarily not nurses. They're mostly direct care professionals supporting people in these settings. To bolster the capacity of our healthcare workforce, we also worked with our partners at the Department of Regulatory Agencies to figure out where we could have regulatory and licensing flexibilities to allow professionals expanded scopes of practice, for example. I mean, we wanted to do everything on the front end that allowed us the most flexibility on the back end. To inform our decisions and actions around staffing, we formed an industry advisory group in the spring. And this group has assisted us in the development of a resource packet that outlined both strategies for managing staff shortages and resources to prevent the burnout that we were seeing very early on among staff. During this time, we also released a poster that was targeted to employees outlining their rights during the public health emergency. Understanding what paid time off they had, what would happen if they tested positive for COVID. There was, I think, a lot of concern early on. And attending to the resident well-being, that really became a priority in the summer months for us. And we issued guidance for outdoor visitation, encouraging safe visits with family and friends. We know that the transmission of the virus is less likely in those outdoor settings. So we, in the beautiful Colorado, worked hard to capitalize on that. We distributed a statement on the use of vitamin D, a supplement that has been shown to have positive effects for people who test positive with COVID. In the fall, we also released guidance for those smaller facilities who really struggled with implementing our cohorting or infection prevention guidelines, that were maybe designed with larger environments, in mind, making sure that those were easily implemented in those smaller home settings. We also updated our PHO to expand visitation allowances, realizing that greater access to loved ones was key to overall wellness and well-being of those residents. At the same time, to ensure that visits were happening safely, we issued guidance on safe holiday gatherings and how to manage that. And finally, with, I think, a continued eye on combating resident isolation and loneliness, we revised guidance around, what does small communal dining look like? What do small group activities look like? Really trying to give, these providers and the residents every tool that we had to help them, really connect with their friends and their families, understanding that these restrictions were perhaps most impactful for them. Of course, as the cases began increasing in the fall, staffing became one of our greatest challenges in the third wave, and we had planned for it. So we responded quickly by establishing a staffing shortage fusion center. Governor Polis secured $1.3 million in funding to directly fill shifts in these residential care settings. And we also trained over 50 National Guards men and women and deployed them directly to help fill shifts in these settings. And through those efforts, we filled almost 5,000 shifts through that third wave to help, again, prevent and mitigate those critical staffing shortages. With that, I am going to hand it back to Scott to talk about testing.
Thank you, Bonnie. Sorry, it took me a moment to get off mute there. There has been no national strategy on testing throughout 2020. The entire country has really suffered from a lack of supplies a lack of laboratories, and an overall lack of strategy coming from the federal government. The Biden administration is putting an enormous amount of effort now into prioritizing the manufacturing of the needed supplies to get testing to the place that it needs to be across the country. Governor Polis has been a huge advocate for testing across the state from before we even had our first case. Our goal has always been that everybody who needs a test can get a test. And I think it is critical to frame this conversation that in the beginning we could do 160 tests a day total across the entire state and only at the state lab. We've now reached a point where our peak testing day was more than 65,000 tests in one day. We have done all that we can do across all of state government to ensure that we scale testing to the place that it needed to be. That has been in partnership with our academic institutions. It has been in partnership with our local public health, our healthcare systems, and with private labs, both in Colorado and across the country. We have built capacity at the state lab so that it's now running 24/7, 365. We utilized the National Guard to stand up one of the first drive-through testing sites in the country. We then utilized the National Guard and created rapid response testing teams to deploy across the state to do testing in our long-term care facilities to bring testing to those who are most vulnerable at a time where it was still incredibly difficult to get testing. We brought on an entire team to source new forms of testing, to source new partners in testing, and that is what has allowed us to scale our testing over the course of this year. We are incredibly excited to see the changes that come from this increased national emphasis on testing from the Biden administration. We did partner with a lab known as Curative. And we partnered with them in the fall to begin doing testing in our long-term care facilities. Several weeks after that partnership began, the FDA did issue a statement on Curative with concerns around the use of Curative for asymptomatic testing. And so after some consultation with FDA, and our own research, out of an abundance of caution, we did decide at the state level to move away from Curative and to pivot to a much more diverse portfolio of testing partners to ensure that we could resume testing in these facilities. We had issued a public health order to make surveillance testing mandatory, and we did have a broad enough portfolio at that point to ensure testing could occur. Next slide, please. And so what you'll see here is the time period between November 16th through February 15th. You can see that the state lab has been providing a consistent level of testing across this entire spectrum. You can see in pink that we really saw a big increase in testing at these facilities in our partnership with Curative. We had issued this public health order to mandate testing because there was still not enough surveillance testing occurring in our long-term care facilities across the state. But again, when we found out that Curative may not be the best test to be used for asymptomatic surveillance, out of an abundance of caution, and because we had created all of these other redundant resources in our portfolio, we were able to stop utilizing Curative, move to other labs, particularly Mako, who has been our partner since early on, to ensure that we were able to keep testing going for this most vulnerable population. And I'll now turn it over to Dr. Herlihy to speak a little bit more about this.
Great, thank you, Scott. So as we replaced Curative with better options, and also in looking back on how difficult things were for residents and staff in long-term care facilities in our fall wave, we decided to do a retrospective analysis of facilities to see if we could detect a difference in outcomes that we may have seen comparing facilities that used Curative to those that used other labs for testing. And in short, what this slide is showing you is that we did not see a substantial difference. So if you look at the left, that table shows you all types of long-term care facilities on the left. And what we see there is no difference in infection rates or mortality rates, depending on whether a facility was using curative or another laboratory for testing during that fall wave of illness. And then similarly, looking at the figure on the right, that focuses specifically on nursing homes. The data comes from the AARP website, and that data is coming from the Centers for Medicare and Medicaid Services. So what we see in that figure is fatality rates that are higher at facilities using other labs in December, and then higher in curative facilities in January, with really no overall clear difference between facilities that were using one test type versus the other. So that's been reassuring for us to see, and was useful to do this analysis to feel reassured that we didn't see impact or harm from curative during that period of time. Next slide. So the next few slides show us the timing of community cases and deaths and long-term, and that's statewide, and then comparing those to long-term care facilities and deaths specifically. So in this figure, counts of long-term care facilities are shown on the left and with gray vertical bars. So you can see that scale on the left. And then all case data are shown in red with the scale on the right. So you'll note that there's clearly a significant difference in the left scale and the right scale when you're looking at case counts overall. But overall, what we see here is that the timing is quite similar. So as community transmission rose in Colorado, cases in long-term care facilities also rose. And as community cases have fallen in Colorado, so have long-term care facility cases. So the number one predictor really that we've seen of cases in long-term care facilities has been cases in the community occurring. Next slide. So here we compare county level maps with counts of all cases during the fall wave shown on the left. So again, that's all cases in the state during the fall wave. And then on the right, we're looking specifically at long-term care facility cases. And so what you see here is that in counties where we see higher numbers of community cases, total number of cases, we also see higher numbers of long-term care facility cases, meaning that the two are really correlating quite closely with each other. Next slide. And this slide shows similar data, but for deaths instead of cases. Again, cases in long-term care facilities rise and fall with community case trends. Next slide. All right. So an important measure of the impact of outbreak prevention and response work is the size of the outbreak. So when strategies in preventing outbreaks or controlling outbreaks are effective, we end up detecting outbreaks sooner. And at that time, they tend to be smaller and able to keep them small with the strategies we have in place. So what this figure shows you is that since September, the average size of outbreaks in long-term care facilities in Colorado has decreased. And I think a lot of that probably has to do with the robust testing strategies that were implemented in these facilities to identify cases as soon as those cases occurred, and then to prevent that next generation of transmission by isolating those cases, quarantining their contacts to ensure that those outbreaks didn't quickly grow. Next, so as a percentage of all cases in the state, the percentage of cases that are in long-term care facilities has decreased over time. And as this figure shows, as of this month, fewer than 1% of cases in the state are among residents of long-term care facilities. Next slide. Similarly, the percentage of deaths in the state that are among residents of long-term care facilities has also decreased over time, and now is at its lowest ever percentage at 24.4%. Bonnie shared with us that that number statewide is around 38%. So you can see that we're well below that average now for the duration of the pandemic. And some of what we believe this decrease that we're seeing in February is due to is probably vaccinations. And Scott is going to talk a little bit more about that and what we're seeing as far as the impact of vaccines in just a minute. Next slide. So finally, I want to share this slide with you. So this analysis uses AARP nursing home data. Again, data coming from the Centers for Medicare and Medicaid Services. And again, shows that deaths in Colorado nursing homes tragically increased as we saw community transmission increase in the state and peaked in the state at a high level in December. This figure also shows us, when we look at not just the dark line that is showing Colorado, but the grayed lines behind it, that there's really quite a bit of variability in timing of other states' peaks and valleys, and also the duration of time that states spend at higher levels is also quite variable. But what you can see over time in this figure is that really, for the most part, Colorado's rate of deaths in nursing homes has been below average consistently throughout the pandemic. And with that, I'll hand it back over to Director Bookman.
Thank you, Rachel. And, at that time that we were seeing that incredible spike in cases, we were doing all that we could at state government, at the local level, to really make sure the public understood the importance of adhering to public health guidance and recommendations to ensure that we knocked this wave down as quickly as possible. Many of you have probably seen Dr. Herlihy's public service announcement, really, just flooding the airwaves with as much communication as possible to ensure that all Coloradans understood the role that they could play, and then did play in bringing that third wave to an end as quickly as possible. Next slide. So there is hope, and there is a light at the end of the tunnel here. Our goal in our mass vaccination campaign is to ensure that we use an equitable strategy to distribute vaccine to save as many lives as possible, as quickly as possible, and to bring the crisis brought on by this pandemic to an end as quickly as possible. It is why the staff and residents within long-term care facilities were the top priority in the initial waves of our vaccine campaign. Really pleased to announce that 100% of long-term care facilities across the state have had their first and second dose clinics completed. That means almost 73,000 residents have been vaccinated, and more than 62,000 staff at these facilities have been vaccinated. And what you will see on the next slide is the outcome of that. An absolutely dramatic decrease in the number of cases occurring in long-term care facilities when compared to the rest of the population at a time period when you would begin to see the immunity from vaccine in these facilities. And so this is the evidence that we have been hoping to see. This is the true light that we have been waiting for. This is the impact that vaccines are having. It is starting to stem the tide of cases in these facilities dramatically, which means that it will start to decrease hospitalizations and deaths associated with this illness. And as we get more vaccines available across the state and everybody gets their opportunity to get this vaccine, we will see cases, hospitalizations, and deaths across our state decrease. Next slide, please. And so with that, we know the importance of visitation in our long-term care facilities. It is a right for our residents of these facilities to have visitation. We know that it is critical for resident well-being to have visitation to decrease the negative impacts of isolation. And as vaccine uptake both within these facilities and across the state increases, we will continue to evaluate more and more opportunities for visitation across our state. And what I really just want to emphasize here is that we know how long this year has been for the residents of these facilities, their family, their staff. It has been incredibly difficult to navigate the challenges associated with this pandemic. And the light at the end of the tunnel gets bigger and bigger every single day. We have greater hope as we get more and more vaccine in, that we are moving towards ending this crisis, the ability to save as many lives as possible. And we are doing all that we can across the state to make sure that we get vaccine into arms as quickly as possible to end this crisis as quickly as possible. Next slide. And so, as always, data transparency is absolutely critical to the state response to this pandemic. You can go to covid19.colorado.gov to see our data, to get more information. And I just want to take a moment to thank all Coloradans who have been wearing a mask, keeping their distance, washing their hands. I want to thank everybody who is so excited to get this vaccine, and to encourage people that when it's your time, make sure you go get that vaccine. It is the key to ending this pandemic, and we are on the precipice of moving in that direction. So thank you all, and Jordan, I'll turn it back over to you.
Great, thank you everyone. We will move into questions and answers now. I know that the raise hand function isn't working for many of you. So we'll just go off of the chat. If you have a question, just let us know and we will get to you. So let's start with Meg, if you just want to say your name and what outlet you're from.
Hi, Meg Wingeter from the Denver Post. You said that 100% of facilities have had the opportunity that people could get their first and second doses. Do you know among residents and staff what percentage actually is?
Yeah, Meg, this is Scott. I can answer that question. And I want to stress that, the vaccinations within these facilities has been part of the federal long-term care facility partnership, which is a federal contract between CVS and Walgreens. And so the data comes from them. And what they've told us is that approximately 88% of residents and 66% of staff have been vaccinated across these facilities in the state.
If I could quickly follow up, for 66%, are you doing anything to try to raise that?
We are continuing to do all of our, public campaigns. We're working with the leadership of these facilities. We're working with the strike team to ensure that, any hesitancy issues in staff are addressed, doing educational campaigns. We know that this is critical to maintaining that immunity in these facilities. And so we are working aggressively to ensure that we have the highest uptake in the staff possible.
Okay, let's move on to John Ingold.
Hi, everyone. It's John Ingold from the Colorado Sun. Just a question for Dr. Herlihy. You mentioned a few times looking at the AARP CMS data, and then also CDPHE has its own data. And I'm trying to understand why there are differences in those numbers, and sometimes for individual facilities, pretty big differences in terms of how many deaths or cases are reported.
Yeah, so some things to know about the AARP data compared to the data that's on our website. So a lot of the summary statistics and figures that we are looking at in Colorado include, and our actions too, and our outreach activities are around all long-term care facilities. When you specifically look at the AARP data, that is focused just on nursing homes. So you're going to see some differences there when you look specifically just at nursing homes versus all types of long-term care facilities. So that's one substantial difference. And then the other is just how the data is collected and reported. So the data on the AARP website is reported through a system called NHSN, and that is facility level data directly submitted by those individual facilities as they identify cases. Much of the data on our website is focused around outbreaks. So when we identify an outbreak in a facility, what the case counts look like, what the number of residents in that facility is, what the number of staff is, and then what percentage of those individuals go on to become cases, or in certain circumstances results in deaths. So we're counting the data in slightly different ways. Also, you'll notice that some of our outbreaks are in progress. Some of them aren't yet closed out. And so some of those numbers on our website might not be finalized until those outbreaks are closed out. So again, I think just different types of data, different sources of data collected in a different way, analyzed in a different way. So there's going to be differences.
Is there any chance that the CDPHE data is missing cases just by focusing on outbreaks? Or is there anything that doesn't rise to the level of an outbreak, but would be going into that CMS data?
Yeah, that's a good point. So we do capture in our CEDARS database, we do capture all COVID-19 cases and deaths as they occur. So that's sort of a parallel system that is separate from outbreaks. There's some challenges though in trying to get what we call denominator data. So we can't calculate, and this is maybe getting a little technical, but we can't calculate rates out of that CEDARS data because we're not, at the same time we're collecting data on those individual cases. We're not collecting data on how many residents might be in that facility at the time of that case. And so if we want to look at rate data, that's when we have to look at our outbreak data, or where we have to go to this AARP data that's collected through this NHSN system. Sorry, I'm happy to follow up and describe it in more detail if you'd like.
No, that made sense. Thank you.
Okay.
Okay, let's go to Jim Anderson.
Yes, thank you, everyone. Jim Anderson, Associated Press. With the new availability of the Johnson & Johnson vaccine, my question is whether the state is and or your team is considering using it in a different manner than the vaccines currently being distributed, either in deployment because it's a one-shot vaccine, offers a little bit more flexibility, if perhaps any thought has gone into perhaps mobile clinics, reaching populations or segments of the population that are harder to reach. Thank you.
I'll take that one. I mean, I want to start off by just, saying how thrilled we are that there is yet another vaccine in our toolkit across the state. And all of these vaccines are safe. They're all effective. The J&J vaccine certainly has a much broader ability to use it, given how the refrigeration requirements versus the freezer requirements. And so we are looking at logistically what is the best way to use this vaccine, and we'll be working with all of our providers to ensure that we're getting the right vaccine to the right provider, to make sure that we have maximum coverage across our state, and really working in all of those different ways that you talked about. We need to stand up mass vaccination sites. We need to do smaller targeted clinics. We need to make sure that everybody has access to this vaccine, and having a third vaccine in our toolkit makes it that much easier for us to do.
Excellent. Do you have any details on at least preliminary thinking along these lines?
Well, I think really looking at how do we bring this into the community. A vaccine that is much easier to work with is obviously easier to bring into the community. And so I think that is one of the places that we're focusing on right now.
Thank you.
Okay, let's go to John Daly.
Hi there, John Daly, Colorado Public Radio. Thanks for taking our questions. I have a question about variants. How worried are you? There's been some predictions nationally that variants could lead to a fourth wave, fourth surge, and also kind of follow up. What do you anticipate the future, the coming months looking like in terms of mask guidance? We're seeing, more events, ball games, concerts potentially looking to open up, other things like that. What do you think that will look like in terms of the guidance from the state in terms of continuing to wear masks?
Sure, this is Rachel. I can talk about the variants. So we are closely tracking transmission of variants here in Colorado. We have a Sentinel surveillance system set up where we're looking at a random sample of specimens from across the state to try and identify which variants might be circulating in the state, where those variants are circulating in the state, and then also so we can longitudinally track whether those variants are increasing in prevalence in the state. And we have seen a little bit of an increase, but not a rapid increase. We're not seeing exponential growth that we can observe at this point with the variants. CDC has talked about the potential that the UK variant, specifically B117, could potentially represent more than 50% or be sort of the dominant variant in the country by mid-March. But they have also said that they expect that the experience won't be the same necessarily across the country. So there might be some states where that variant might spread more rapidly in other states where the variant might spread more slowly. Certainly what we are concerned about with the B117 or UK variant is the fact that it does appear that that variant is more transmissible. It also does look like there's some early data that suggests that it could be causing more severe illness. And so there is the potential there that, you know, we could see rapid spread of that variant, which could result in another wave of illness. With increased severity of illness, we could also see, you know, additional stress on our healthcare system. But based on the modeling data that we've looked at, so the modeling work we're doing together with the Colorado School of Public Health, you know, it looks like there's really very limited sort of boundary sort of scenarios where we really see risk of exceeding our healthcare capacity in the future, even with variants being transmitted in the state. And I think that really has to do with, you know, the growing level of immunity in the state, both, you know, because of prior infection and then now obviously because of vaccine rollout, and specifically targeting those populations that are most at risk of hospitalization in the state. So, you know, certainly variants are concerning. We know that they could be a setback in our response, but at least with the variants that we are seeing here in Colorado, the B117 variant and another California variant, we think that we're doing okay right now and continuing to make progress with gaining immunity in the state.
And then to take the second half of that question, masks save lives. And we have not reached the point yet where we have enough vaccination done that we can let our guard down. And so the simple act of wearing a mask has the ability to save lives and to keep this crisis at bay. And so it is absolutely critical that in the coming months, we continue to wear our masks, continue to follow this public health guidance until we have enough vaccines in state and administered to reevaluate that guidance.
Okay, and then it looks like the Fox 21 newsroom has a question.
Hi there. Yes, it's Carly Moore with Fox 21. Thanks so much for taking our questions. Kind of have a similar question that Jim asked, and that was just with the approval of this third Johnson & Johnson vaccine. Do you guys know how soon Colorado will receive this vaccine and how soon we will be able to distribute it, and then what that means as far as availability for everyone? Does that speed up vaccine timelines? Will we be done with this process sooner, or what are you thinking?
Well, we're continuing to wait for a little bit more clarity at this point from the federal government. We do know that we're going to receive, about 45,000 doses this week of the J&J vaccine. We're still unclear on exactly when it's going to arrive. And we don't know what supply we're going to have after this week. And so we're incredibly excited. Having a third vaccine approved just adds to that supply. And we are certainly hopeful that in the coming weeks, we will see a significant increase in vaccine availability across the state, allowing us to move to vaccinate more and more people on a faster timeline. But at this point, we still are waiting to understand, and we are still fully dependent on that federal vaccine supply.
Okay, and I know that we have just a couple minutes left, so we have time probably for maybe one or two more questions. Again, I just want to reiterate, if we don't get to you, I know there's quite a few of you in line, please email the media_info@state.co.us with your questions, and we'll make sure to get back to you. For now, let's wrap it up with Jason.
Yes, Jason Grenauer here from Denver 7. What about people who have a vaccine preference that want to get one brand name over the other, as well as we move into the next phase that involves essential workers and or some essential workers and people with pre-existing medical conditions? How are those things going to be proven? Do you need a doctor's note or are things going on the honor system? Thank you.
So all of these vaccines are safe and effective. And what I really want to encourage the public is that when it is your turn to get this vaccine, it doesn't matter whether it's Pfizer or Moderna or J&J or any future vaccines that are authorized. every one of these vaccines is safe. Every one of them is effective. And when it is your turn, we hope you will take it, roll up your sleeve, get this vaccine so we can move towards ending this crisis. As far as our continued work as we move through our phasing, when we look at our essential workers, we are going to be working with employers. We're going to be working with providers. We will be setting up our own points of distribution and mass vaccination clinics across the state to serve everybody who is currently eligible in their phasing. And we'll have more info on how to sign up in the coming days and coming weeks.
Okay, and that's all we have time for today. Thank you, everybody, for joining. Again, if we didn't get to your questions, please send us an email and we'll make sure to get you a response. Thanks, everybody.